Good evening, friends. Shall we start the class?
Okay, sure, sir. So, everybody, welcome to MedMeet 2.0 lecture series as part of MedMeet 2.0. Today, we have a very special class by Dr. Rajamahendra, sir. Thank you so much, sir, for being here.
Thank you.
Also, just a note to all the participants here, there will be a quiz at the end of the session. So, please make sure to stay back for the same. That's it, sir. Over to you, sir. Thank you.
Thank you. Thank you. Good evening, friends. Today, we are going to have an interesting topic. It's actually a long case in your exams for final year exam. Let us start with obstructive jaundice. To understand obstructive jaundice, it's very simple. So before going into the topic obstructive jaundice, let me tell you the other names of this obstructive jaundice are surgical jaundice. Okay. So I am Dr. Rajamahendran, surgical gastroenterologist from Villupuram Medical College, Tamil Nadu. So I'm the director of RRM Next PG Coaching Center and also the surgery faculty in Dr. Tutorials. So let us now start with obstructive jaundice. Please understand the other name of obstructive jaundice is also called as surgical jaundice. It is also called as surgical jaundice because it is dealt by the surgeons and these jaundice can be cured by surgery. That is why it is known as surgical jaundice, and most of this jaundice will get immediately relieved by some methods of surgical procedures. So please understand the anatomy here. To understand the surgical jaundice, you should understand the anatomy. This is right side hepatic duct. This is left side hepatic duct. Now it becomes a common hepatic duct, and this is a common bile duct after joining with the cystic duct. This is gallbladder. So right duct, left duct, common hepatic duct, common bile duct, and this is gallbladder with a cystic duct. So what is the normal length of common hepatic duct is 2.5 centimeter. Common bile duct is 7.5 centimeter. Okay, and here you should not forget the main function of this bile duct is to carry the bile and other products from the liver. So bile produced in the liver. So there's a bile produced in the liver, which is containing bile salts, cholesterol, bile pigments. Everything is now carried by the bile duct. Okay, everything is now carried by the bile duct. Please remember, this is a bile coming into the bile duct, and it gets concentrated up to 50 times in the gallbladder. Then it is going into the bile duct and joins along with the major duct of Wilson. This is a pancreatic major duct of Wilson. It joins with the Wilson and opens into the duodenum. So this is the second part of duodenum at the level of ampulla of Vater. At the ampulla of Vater, it opens into the duodenum. So here you should understand the basic thing. I am going to deal with a chapter which is going to have obstruction along this pathway. So the obstruction is along this pathway. Anywhere along this pathway, if there is an obstruction, that is my topic. That is called as surgical jaundice. So please understand this concept, anatomy. So anatomy behind the topic is, this is the anatomy behind the topic. And now some physiology from this topic. Physiology related to obstructive jaundice. So I told you very clearly, it is the bile pigments, bile salts, which are going to come into the duodenum. So bile salts are now not able to come into the duodenum. So bile salts are not entering into the bowel. So what is the function of bile salts? So just some basics before going to the topic. Bile salts' main function is to digest fat. Digest fat. In fact, absorb fat. Fat absorption is done by the bile salts using the classical method of absorption of bile salts is by forming micelles and various methods. This will be discussing in physiology and biochemistry. And another important function is it is very important for absorption of A, D, E, K because these are fat soluble vitamins. So fat soluble vitamins like A, D, E, K is also absorbed by the bile salts. So when there is no bile salt in an obstructive jaundice patient, bile salts are not entering into the GIT. When the bile salts are not entering into the GIT, fat is not digested, number one. Number two, there will be deficiency of ADEK. And as a surgeon, for me, very important is vitamin K deficiency. So I am very much worried about vitamin K deficiency. So even that fat will be digested by the pancreatic juice, but vitamin K deficiency is very essential point you should note here. Vitamin K is essential for extrinsic pathway of coagulation. So because of the extrinsic pathways involving 2, 7, 9, 10, these factors are produced by vitamin K. So therefore, please understand the basics. Without understanding the basics, if you go to the topic, you will not understand. That is why I'm telling you the basics. So vitamin K deficiency is very commonly seen. So therefore, 2, 7, 9, 10 is deficient. And these patients will have increased prothrombin time or INR. So whenever you see a bile salt deficiency, in any case, there will be vitamin K deficiency characterized by loss of factors 2, 7, 9, 10, resulting in PTINR. Please understand, when there is a PTINR high, I cannot do any procedure. Therefore, the moment I see an obstructive jaundice patient, immediately I will start putting injection vitamin K, IM. See, very important. So whenever I see an obstructive jaundice patient, immediately I should put them vitamin K, IM, because definitely their prothrombin time and INR will be elevated. This is one of the important physiology. So bile salt essential component, bile salt is deficient in these patients. So they may have vitamin K deficiency. So I have to give them injection vitamin K. So this is a physiology related. Anatomy, I'm just giving the basics. Anatomy, don't forget the anatomy of bile duct. Bile duct is common hepatic duct is 2.5 centimeter, bile duct is 7.5 centimeter, and there is ample of water which is relaxed by whom? Who relaxes ample of water? Cholecystokinin contracts gallbladder and relaxes sphincter of OD in the ampulla. Sphincter of OD in the ampulla is relaxed by cholecystokinin. So this is a very basic physiology you should not forget. Now, at this point of time, you should not forget there is bile salts and bile pigments are not able to enter into the bowel. So the most important bilirubin here is conjugated bilirubin. So the most important bilirubin should be noted here is conjugated bilirubin. Please don't forget, conjugated bilirubin should enter into the bowel, and this is very important for maintaining the color of the stools. It is because of this conjugated bilirubin, yellow stools are happening. So now in an obstructive jaundice, conjugated bilirubin is not entering into the bowel. So therefore, what happens? The stool color will be clay color. It's a white clay color stools. That is a very important clinical feature. So clay color stools are seen because conjugated bilirubin is unable to enter into the bowel, number one. And this conjugated bilirubin, which is accumulating in the liver, will regurgitate into the bile, into the blood vessels. In the hepatic sinusoids, it will regurgitate back into the blood vessels, resulting in increased direct bilirubin or increased conjugated bilirubin in the circulation. So increased direct bilirubin will be there, and this direct bilirubin in the blood will be excreted in the urine, causing high colored urine. High colored urine is seen in these patients. So it is yellow color urine. Therefore, this increased direct bilirubin will settle in various places like in the cornea, in the conjunctiva or sclera. You can say it as sclera, becomes yellow. Under surface of tongue, there will be yellow. Nail beds, all these places will become yellow. So the bilirubin will get deposited in the sclera, tongue, nail beds, everywhere. So the patient becomes yellowish. And please remember, the bilirubin pigments will get deposited in the skin. In the skin, it causes itching. Because of the bilirubin pigment thing, because they have. So there will be itching seen. There will be itching seen in the patient. So itching is a classical feature of these patients. So with this thing in mind, let us go to the topic. Okay, let us go to the topic with this clinical features and other things. So don't forget what are the things I told you. We have to follow those things classically. So now this is a clinical approach to obstructive jaundice. Now tell me, what are the causes of obstruction of the biliary tract? So this is a biliary tract. What are the causes of obstruction of biliary tract? So there are many causes. You can do some classification, whichever you want, but I will tell you congenital causes. Congenital causes of obstructive jaundice. Number 1, extrahepatic biliary atresia. Number 2, choledochal cyst. So choledochal cyst and extrahepatic biliary atresia are two pediatric conditions. So that will not be kept for your exam. So don't worry about it. So the two congenital causes are extrahepatic biliary atresia and choledochal cyst. I'm not going into that. And benign causes in the biliary system and malignant causes in the biliary system. There are only 3 causes. One is congenital, and in adults there is benign and malignant. So in benign causes of obstructive jaundice, the most common is an obstruction by stone. Stone obstruction in the biliary tract. Obstruction of the biliary tract by the stone is the commonest cause. Stone obstruction. Stone obstruction is the commonest cause in benign cases. So most common cause is stone. Please don't forget. In benign cases, the most common cause is stone. In malignant cases, the most common cause is cancer. So what cancer? The cancer can be in the bile duct cancer, or periampullary cancer, ampulla cancer, or head of pancreas cancer. So any cancer which can occlude, the cancer which can occlude intraluminally or from extraluminally. So intraluminally you have the cancer in the bile duct like this, bile duct cancers. So cancer in the bile duct can cause obstructive jaundice. Cancer in the ampulla can cause obstructive jaundice. A cancer in the head of pancreas can compress the bile duct and can cause cancer. So cause jaundice. And sometimes the gallbladder cancer, the cancer from the gallbladder can grow extensively and it can also cause cancer. Number 4, GB cancer. So many causes are there. In benign cases, there are still more causes like Ascaris worms. Obstruction by Ascaris worms. Please don't forget Ascaris worms. And obstructive jaundice caused by Clonarchis. Though it is not seen in India, it is Clonarchis sinensis, Chinese liver fluke, that can cause obstruction. Ascaris can cause obstruction, or any injury to the bile duct during surgery, like bile duct injury. Bile duct injury during cholecystectomy or any other surgery can cause a stricture. That stricture can cause jaundice. That stricture can cause jaundice. And don't forget primary sclerosing cholangitis. Primary sclerosing cholangitis is another condition which is an acquired benign cause seen in ulcerative colitis patients. In ulcerative colitis patients, you develop primary sclerosing cholangitis. So these are the various benign causes. So lots of benign causes are there. Lots of malignant causes also there. So the simple method to differentiate whether it is a benign or malignant by a clinical examination, the clinical examination method is called as Courvoisier law. How to say whether it is benign or malignant is by means of a simple law known as Courvoisier law. It is nothing but a clinical examination of an obstructive jaundice patient. So these patients will be now examined clinically. So on examination clinically, in first patient, there is an enlarged gallbladder like this. In the second patient with obstructive jaundice, there is no enlarged gallbladder. It is a small gallbladder. So on palpating an obstructive jaundice, if there is no gallbladder palpable, what is the cause? When there is no gallbladder palpable, it is due to stones. Stones in the bile duct. In the stone disease, gallbladder is not palpable. It is because this stone would have come from the gallbladder to bile duct. It is because the stone would have come from the gallbladder to bile duct and would have caused this obstruction. So it is stones in the bile duct. There is no gallbladder palpable. Please don't forget this point. So no gallbladder palpable. There is a stone in the bile duct. This is one reason. Why gallbladder is not palpable in a stone disease? Because this stone would have come from the gallbladder, which is already so many times had cholecystitis. Therefore, this is a fibrosed gallbladder. So a fibrous gallbladder will not get more enlarged. That is the reason here we are not able to palpate the gallbladder. Whereas if it is a cancer, please understand, if it is a cancer in the distal bile duct, if there is a cancer, immediately gallbladder can enlarge up to 50 times. 50 times it can enlarge, 50 times it can concentrate. Please don't forget. So it can enlarge even up to the right iliac fossa. It is one of the important differential diagnoses of right iliac fossa mass. Up to that much size, it can get enlarged. Because it's a normal gallbladder, it has a good elastic wall, so it gets enlarged and accumulates the bile. So this is what Courvoisier said. What Courvoisier said? If it is due to stone, gallbladder not palpable. If it is due to cancer, gallbladder palpable. This is what Courvoisier said, and our people found out two exceptions. Exceptions to Courvoisier law. Exceptions to Courvoisier law. In which condition, though it is a cancer, gallbladder is not palpable. Yes, cancer, but gallbladder not palpable. Which cancer? Cancer is not, gallbladder not palpable in a proximal cancer. In a hilar cholangiocarcinoma. In a hilar cholangiocarcinoma, gallbladder is not palpable because it is proximal to the gallbladder. It is proximal to the gallbladder, so gallbladder not palpable. So one exception, though it is a cancer, gallbladder not palpable. Though it is a stone, but still gallbladder is palpable when? When there is one stone in the bile duct, another stone in the cystic duct, known as double impacted stone. So double impacted stone, one stone in the cystic duct stone causes enlargement of the gallbladder due to mucocele. Mucocele of gallbladder is seen in those cases. So therefore, mucocele of gallbladder is a cause of enlarged gallbladder. So this is an exception of Courvoisier law. The only clinical examination the examiner will be waiting to get from you is about the Courvoisier law. So if you tell Courvoisier law, I'm telling you, if you're in an obstructive jaundice case, you are passed. Courvoisier law says, in case of obstructive jaundice due to stones, gallbladder is not palpable. Obstructive jaundice due to cancer, gallbladder is palpable. The exception of Courvoisier is, in a hilar cholangio cancer, gallbladder not palpable. In a double impacted stones, gallbladder is palpable. That's all. This is simple Courvoisier law. Don't get confused with this Courvoisier law. Okay, this is very basic point. Don't forget now. So now let us start with the history taking of an obstructive jaundice patient. So a patient, Mr. Kumar. Okay, Mr. Kumar, 60 years male, comes to you with the complaints of jaundice. This is the history. This is a case coming to you with the jaundice. Let me show you Mr. Kumar now. So with the best wishes from my hospital, RRM Gastro, and from my institute, RRM Next Institute, we are starting this session. So this is the patient now. See the patient classically. So you can you see there? There is some, whether you could note, this is a mass. That mass is nothing but enlarged gallbladder. So as he is doing respiration, there is a mass moving with the respiration. Okay, that's a classical case. Now let us ask about the various history. So patient has come to me with the jaundice. So now I ask jaundice history. So whether the jaundice is associated with pain or painless. So what are the causes of painful jaundice? What are the causes of painless jaundice? Very important. So first question, I'm asking jaundice, whether the patient is having any abdominal pain. So painful jaundice is usually due to stone disease. Because stone disease will definitely cause pain. Painless jaundice is usually due to cancer, but not always. Not always. It is usually due to cancer. In cancer, some cancers can cause pain. See, please remember, cancer like hilar cholangio cancer. Hilar cholangio cancer can be associated with pain. Pain is present. Periampullary cancer has no pain. Periampullary cancer has no pain. And Head of pancreas cancer, I already told you they also have pain, and pain in the epigastric region radiating to back is present in head of pancreas. So pain is present in stones and in hilar cholangiocancer. So which cancer has no pain means it is periampullary cancer. It is a periampullary cancer, usually does not have any pain. So this is very important. So, and about the jaundice, whether it is progressive jaundice or intermittent jaundice, you should ask whether the jaundice is progressive or intermittent. The patient will tell, last month I had similar symptom and it suddenly got relieved. So who will have progressive jaundice? Progressive jaundice is seen with cholangiocarcinoma, bile duct cancer, cholangiocancer, and head of pancreas cancer will have progressive jaundice. Intermittent jaundice is seen in periampullary cancer. Here is a very important point. Periampullary cancer has painless intermittent jaundice. That is a classical MCQ. Why periampullary cancer is having painless intermittent jaundice? Can you tell me? So this is an ampulla. Periampullary cancer is a cancer which is slow growing cancer like this. It will grow and obstruct the lumen and patient develops jaundice. But after some time, what happens? This tumor will get sloughed out and falls down. Tumor sloughs out. As the tumor sloughs out, you will get immediate reliefs of jaundice. Again, the tumor will grow and obstruct. So like that, it will be intermittent painless jaundice. So don't forget the MCQ, which is painless intermittent jaundice. Answer is periampullary cancer. Which is painful progressive jaundice is cholangiocancer and head of pancreas cancer. So who will have associated with fever or not? Fever is present in which condition? Fever is a sign of cholangitis. When the bile duct gets obstructed and gets fever, it means it is cholangitis. What is the triad seen in cholangitis? Can you tell me the triad? The triad is called as Charcot's triad, which is characterized by pain, jaundice, fever. So pain, jaundice, fever. It is also known as intermittent pain, intermittent jaundice, intermittent fever. It is a classical feature of CBD stone. Please don't forget. So when there is a cholangitis happening, it is due to intermittent pain, intermittent jaundice, intermittent fever is classically seen in CBD stone. And if you're not going to treat the CBD stone immediately, they will land up in Reynolds pented. What is Reynolds pented? It is characterized by pain, jaundice, fever, plus septic shock. Septic shock and mental changes. The patient will become unconscious, mental changes. So septic shock and mental changes are associated with Reynolds pented. So when a patient comes to you with a fever, altered sensorium, pain, jaundice, fever, think of CBD stone causing cholangitis. Very important point, that case will not be kept for your exam because patient is very sick. They have high mortality, so we have to operate them at the earliest. So a CBD stone with a cholangitis will not be kept, but you can ask history of fever. So history of fever suggests patient has cholangitis. Don't forget this point. So what are the important things I should ask? Whether it is a painful jaundice, painless jaundice, whether it is a progressive or intermittent, or whether it is having fever or not. So these points and all you should classically ask in these patients. So because these are the elaborating history of elaboration, jaundice, fever you should ask. And I told you what are the features of obstructive jaundice. You should ask history of features of obstructive jaundice. So features of obstructive jaundice, I told you when I'm examining patient, you should ask history of passing clay color stools. Please don't forget the stools color is clay color stools. Number one. History of passing yellow urine. Okay, number two. And history of itching all over the body, they will have severe itching. So clay color stools, yellow urine, itching are the three clinical features you should never forget. Clay color stools, yellow urine, itching, and history of any bleeding. I told you, they may have prothrombin time INR elevated. So they may have it due to increased prothrombin time INR due to vitamin K deficiency. There can be history of any bleeding. There can be history of any petechial bleed or etc. So they will not have a massive bleeding. Any bleeding anywhere, when small gum bleeding or any bleeding, you should ask whether there is any history of bleeding. You should tell the patients may have vitamin K deficiency. So I want to rule out any increased prothrombin time, and INR. These are the features of obstructive jaundice. See, at this point, I'll tell you, there will be also another case which is similar, which is a medicine case known as medical jaundice. So medical jaundice is a classical case. You can easily identify they are nothing but cirrhosis patients. Medical jaundice cases are nothing but decompensated liver disease plus ascites. This is the medicine case. They will have jaundice, DCLD with ascites. Very important point, they will have a yellow stools only. They won't have clay stools. They have yellow stools. They have yellow urine. Okay, they have yellow urine and yellow stools. Both are yellow in medical jaundice. So medical jaundice case patients will have features of DCLD. DCLD features, I hope you know, are in otherwise features of portal hypertension. Portal hypertension features. I hope you should know the portal hypertension features like hematemesis. Okay, hematemesis, bleeding per rectum, splenomegaly. So those cases will not be kept in surgical ward. Okay, don't worry about it. So patients of medical jaundice who are having yellow stools, yellow urine, it is purely due to medical jaundice. So that case will not be kept for your exam. You will be going to get an obstructive jaundice case. So obstructive jaundice case, history of clay color stools, history of yellow urine, history of itching, history of bleeding. And you should ask about any treatment history done for the patient. So many times the patient would have taken some native treatment. Definitely they will tell native treatment I took. I took some native treatment. That definitely they will tell you native treatment history. And ask about history of any gallbladder surgery. Because any gallbladder surgery done before can result in bile duct stricture. Bile duct stricture can happen due to previous gallbladder surgery due to bile duct injury. That patient can now present to you with a obstructive jaundice. So ask for any history of treatment. So please don't forget what are the histories to be asked. These are the points to be asked. Painful jaundice, please don't forget stone. Painful jaundice progressive is hilar cholangiocancer. Jaundice with back pain is head of pancreas cancer. Painless intermittent jaundice is due to sloughing of the tumor. Periampullary cancer will have sloughing of tumor. So now this is about the history taking. Now we go to the examination in detail. So the moment you see an obstructive jaundice patient, you should examine for jaundice in the conjunctiva, oral cavity on the undersurface of tongue, and nails. In the nails, you should not only see for jaundice. There is another interesting point known as shininess of the nail. Why? Because of continuous scratching of his abdomen all the time, his nails will be shiny, shining nails. Shininess of the nail is loss of shininess of the nail is wrong. It is shininess of the nail. So the normal nature of the nail is gone, and because of continuous scratching, the nail will be looking shiny, shiny nails. Okay, shiny nails are present, and you can see the scratch marks everywhere in his abdomen and body. And when you do a rectal examination, you should look for clay color stools. So these are the findings to look for jaundice. Don't forget to look for the jaundice related features. And these are the general examination. You can see this is these are all native treatment. You can see this in yellow color band tied in the arm. It's a jaundice treatment, native treatment. You can see a burns being made with an iron rod. It is also a jaundice treatment. In native places, you can see another heated iron rod. So the people in the native place, they think by heating with an iron rod, jaundice will get reduced. So there's a classical native treatments done. There's another patient with a native treatment. All these patients will be delayed unwantedly because of local native treatments. Don't forget native treatment. See the classical jaundice, eye jaundice. Patient having yellow eyes and yellow tongue. This is a classical eye jaundice. You can see the patients having scratch marks on the hand. You can see scratch marks because of the itching. They will have overnight itching. Many patients, in fact, come to us with the scratch marks. Don't forget this. See the shining nails. The nails become smooth and shiny because of continuous scratching. All these points you should find out. And now coming to the local examination of the abdomen. So in abdominal examination is very important for a surgeon. Abdominal examination, first basic point I should see on inspection is I will easily diagnose whether it is a surgical jaundice or a medical jaundice by an abdominal examination. If it is a medical jaundice, what are the abdominal findings? Can you tell me? In a medical jaundice, what are the abdominal findings? There will be number one, dilated veins, like dilated veins coming towards the umbilicus known as caput medusae. Okay, there is, you can see ascites. Sometimes massive spleen can be seen in the abdomen. So ascites, dilated veins, spleen, all these are classical findings in the abdomen in a medical jaundice. But in a surgical jaundice, what are the findings seen? Surgical or obstructive jaundice, what are the abdominal findings? Please remember, there will be no big finding at all. That is a very important one. Obstructive jaundice on inspection, you cannot see anything. There will be only scratch mark. If the gallbladder is very much distended, you can see it moving with the respiration. So gallbladder distended, as per Courvoisier law, you can see a gallbladder moving with the inspiration. Because of the Courvoisier law, you can sometimes see on inspection gallbladder. Very important, previous surgical scars. Previous scar means probably a bile duct surgery done and we have injured the bile duct. Previous scar of cholecystectomy should be noted. And especially nowadays, we are doing laparoscopic cholecystectomy. So you should look for lap scar in the abdomen. So you have to look for the laparoscopic scar in the abdomen. So scratch marks, gallbladder distended, and previous scar you should look for in the obstructive jaundice patients. Don't forget these points. So medical jaundice and surgical jaundice, you can see some points on inspection. Coming to the palpation, you can easily say it is a surgical jaundice because the moment you keep your hand, you can see a enlarged liver. Because of an obstructive jaundice, liver can be enlarged and it will be firm in nature. And you have to now look for gallbladder from the right iliac fossa to right hypochondrium. You should go from right iliac fossa and palpate up to the right hypochondrium from below upwards. So you can palpate the gallbladder. Don't forget, if you miss examining the gallbladder, you are not going to get good score in obstructive jaundice. See, because the examiner will be waiting only for this finding. You have to say whether the liver is enlarged, whether you could palpate the gallbladder separately or not able to palpate. If you are able to palpate, what is it? It is a case of cancer patient. If you are not palpable, it is going to be a case of benign case. So don't forget this point. Benign like stone. So benign stone disease, you cannot palpate the gallbladder. In a palpable, you can see a cancer, you can palpate it. This is a classical Courvoisier law. So please don't forget to tell about this enlarged gallbladder because that is the only thing the examiner will be waiting from this obstructive jaundice case. You have to tell about the enlarged gallbladder. Then percussion, auscultation and all not so significant. And finally, you have to come to a diagnosis. So diagnosis of the patient is classically you should tell it is in a case of obstructive jaundice. So I feel my patient is having an enlarged gallbladder, old age, and patient is having a progressive painless jaundice. So probable cause is what? Probable cause of my patient is a periampullary cancer. So I will go for a diagnosis as periampullary cancer. Like that, you should give a probable diagnosis. Don't tell like it can be a stone or it can be a cancer. You should be sticking with your finding. In a clinical examination, if gallbladder is palpable and if the patient is old age, patient had no pain, all these features you should go in for a cancer. The patient is having pain, cholangitis, no gallbladder palpable, go for a stone disease. But I'll tell you a clue here. They won't keep stone disease for your exam. They'll only keep cancer for your exam. Obstructive jaundice due to periampullary cancer or head of pancreas cancer will be the exam case. They won't keep any other case or even cholangiocarcinoma. So cholangio cancer. So one of this will be the exam case for your exam. So don't forget this. So which case will be kept for the exam? These are the case you should not forget. Okay, periampullary cancer, head of pancreas, and cholangio cancer will be one of your exam case. So you can see a patient with a medical jaundice having ascites with the dilated veins over the abdominal wall. This is a classical medical case. So we will not be discussing that case. And you can see a patient here with a dilated veins over the abdominal wall. This is also a case of Bucchiari syndrome causing cirrhosis and medical jaundice. So this is a case of medical jaundice. So as though it is a medical jaundice, you have to tell if you see a dilated vein, you tell about it. But mostly dilated veins are features of cirrhosis. Okay, that is you should not forget that. And don't forget to miss to palpate for left supraclavicular node. that is Troisius sign. Any abdominal malignancy can have left supraclavicular node. Already we have discussed about it in many surgical cancer topics. Okay, this is very basic point. You should not forget. And don't forget to tell about the scar. What is the name of this scar shown here? The scar shown here is a cholecystectomy scar known as Cocker's incision. This is a Cocker's incision, which is a cholecystectomy incision. When you do a gallbladder surgery, this incision will be there. And if this incision is there and the patient is having an obstructive jaundice, classically patient had a bile duct injury. Okay. So now you can see palpable gallbladder up to the right iliac fossa. The gallbladder is palpable. So it is a case of cancer. You can see such an enlarged gallbladder here. Such an enlarged gallbladder indirectly implies it is a cancer only. So this is an intraoperative image of a periampullary cancer. So don't forget, this is a periampullary cancer showing you enlarged gallbladder. And finally, don't forget to tell, I will do perrectal examination to see for clay color stools. This is a clay color stools you are seeing here in the patient. So this is a classical stool because there is no bile pigment mixing. So the stools will be pale white or clay color like this. Sometimes you can get a stool like this. What is the name of this sign? So this is a stool where clay stool is mixed with what? Mixed with blood. That is nothing but melena. So blood is mixed with the clay stool, gives a sign known as silver stool. Silver color stool. The sign is known as, what is the name of the sign? Anybody? I could not see the chat box because I am using only one system. Yeah, very good. That is a Thomas sign. Very good. Pooja, Subhashini, Rajesh Krishna. That's correct. So that is known as Thomas sign. Very good. So any doubts, we will explain you later. Thomas sign. That sign is known as Thomas sign. So most of your doubts will be clarified at the end of discussion. So just follow this discussion. At the end, if you have any doubts, we will discuss. So this is Thomas sign. That is known as Thomas sign. Clay color stool mixed with the melena. Who will get Thomas sign? When a periampullary cancer, I told you they will slough out. In a periampullary cancer, when the tumor sloughs out, there will be bleeding also. So blood mixed with the clay stool gives a Thomas sign. So sloughed time, during the time of sloughing of tumor, you get this classical feature of Thomas sign. Okay, Thomas sign. So Charcot stare, don't forget Reynolds Pented and Charcot stare. They repeat basic questions. This is a Kurvaisierla, fibrosed gallbladder in a CBD stone, enlarged gallbladder in a cancer in the bile duct. Okay, so this is a picture showing you double impacted stone. See, there is one stone here, there is another stone here. We have removed the enlarged gallbladder. You can see it is not filled with bile, it is filled with mucus, clear mucocele of gallbladder. So mucocele of gallbladder can give an appearance as enlarged gallbladder. So systemic examination, what to see means you have to see for signs of liver cell failure. Though I'm not discussing a medical jaundice, I should look for gynecomastia, liver failure like parotid swelling, all those things. Medical jaundice features should be looked after. So ecchymosis, any bleeding spots, any distant met spots, all these points should be noted in a systemic examination. So now the picture, this is a case of obstructive jaundice and the cause of obstruction implies the site of obstruction also. So the site of obstruction is distal to the cystic duct or at the level of common hepatic duct or common bile duct or ampullary level. Like that you can tell, but it is not needed. This first point and the last point is very important. This is a case of obstructive jaundice and the cause of obstruction is due to dash. Okay. So now, how are you going to approach this case? I'm going to write a very interesting protocol in the management of obstructive jaundice. So you can understand step by step in this protocol. So now you have confirmed a patient coming to you with an obstructive jaundice. How are you going to proceed? So an obstructive jaundice patient, first of all, I want to come to a conclusion. It is an obstructive jaundice. So basic investigation I will do is blood investigations. So in a blood investigation, what findings I want to know? So in a liver function test, I want to see there is direct bilirubin increased more than the indirect bilirubin. This is very important. Increase direct bilirubin than indirect bilirubin, because in a medical jaundice, indirect bilirubin will be more than the direct bilirubin. First point. And very sensitive finding for obstructive jaundice is what? Serum alkaline phosphatase is an sensitive indicator of obstructive jaundice. So it is sensitive indicator of There is an obstruction of the bile duct. In a case of medical jaundice, increased SGOT, increased SGPT will be seen in medical jaundice. So I can easily say what type of jaundice is by doing a liver function test. So the first test I will do is always liver function test. The second important test I should do is prothrombin time INR. Without doing prothrombin time INR, I will not even do anything for the patient. So PT-INR will be usually increased. I told you, because of the absence of vitamin K, PT-INR is increased. So before proceeding for further investigations, immediately put injection vitamin K for the patient. Vitamin K, I am started for the patient daily. So injection vitamin K daily, at least 3 days, if you give PT-INR becomes normal. In an obstructive jaundice patient, if I give vitamin K for 3 days, PT-INR will become normal. Okay, this is very basic point. So this is the first important thing, blood investigation. And if the patient is having fever, that means what? Patient is having cholangitis. So look for a WBC count. WBC count is increased in a case of fever patient. So suspected fever patient, there will be increased WBC count in a cholangitis. So whatever it is, basically first to do blood investigation. So what is essential for this case, I'm telling you, we will do the blood investigation. After the blood investigation is done, what is the first done radiological investigation for an obstructive jaundice? First done radiological investigation is ultrasound of the abdomen. Ultrasound of the abdomen will give me a clue whether it is a jaundice due to stone or due to cancer or due to anything else. I will see a classical finding in an obstructive jaundice. Ultrasound will show me a very interesting finding that must be asked by the examiner usually. That is dilatation of the biliary radicals inside the liver. Because of obstruction, there is dilatation of biliary radicals. Dilatation of intrahepatic biliary radicals. Please don't forget this. So because of obstructive jaundice, there is dilatation of intrahepatic biliary radicals. And you can see whether there is a stone or any cancer, but though it is not conclusive, you can get an idea whether the gallbladder is enlarged or whether the gallbladder is having any stone. All these things, everything you can find out in an ultrasound. But it is not confirmatory evidence, but it is a first done investigation. If there is a stone in the gallbladder, what will be the finding in an ultrasound? Stone in the gallbladder will have what finding in ultrasound? It will have a posterior acoustic shadow. I will show you this, an image-based question for PG entrance exams. It is posterior acoustic shadow. Posterior acoustic shadow is a finding of stone in the gallbladder. And another finding is this stone will move when you turn the patient. When you turn from left to right, the stone will move. So moves with position. So moves with position and posterior acoustic shadow are the two important findings of this patient. So posterior acoustic shadow is seen and the patient moves with the position of the patient. So moves with the position. The stone will move with the position. This is for stone. So ultrasound anyhow will give just a classical idea whether the patient is having any stone or cancer. But now for an obstructive jaundice patient, what is the investigation of choice to find out what pathology it is? So after doing the first done ultrasound, I should send the patient for investigation of choice. That is, please don't forget MRCP. This is the protocol. Don't bypass the protocol. You should follow this protocol. Blood test, ultrasound, MRCP. MRCP is nothing but T2 weighted MRI. T2 weighted MRI, all of you know that in a T2 weighted MRI, liquid appears bright. So classically, you can see an extraordinary anatomy. So it is an anatomical image of bile duct. It's an anatomical image of bile duct and pancreatic duct in this MRCP. So this MRCP will show you what is the disease, whether it is a stone disease or it is a cancer is now classically identified with the help of MRCP. Because in a cancer, there will be a tapering appearance like this. There will be a tapering sign. Tapering of the bile duct is seen in cancer. Whereas in a stone, what sign is seen on MRCP? In a stone, there will be one interesting clinical finding known as, what is this sign? Known as Meniscus sign. Meniscus sign is a finding of stone. Tapering is a finding of cancer. Another finding in cancer is because of a cancer in this place, bile duct will be dilated and pancreatic duct also will be dilated. This sign is called as double duct sign. So double duct sign is a feature of cancer in the head of pancreas or in the periampullary region, and meniscus sign is a finding of CBD stone. CBD stone will have meniscus sign, cancer will have double duct sign. Just remember this. These are just clue from the MRCP. From the MRCP, you get these findings. And now, what am I going to do further? So if it is a cancer, now it becomes a cancer, what will I do? If it becomes a stone, what will I do? It has become a CBD stone. What should I go for next? A patient is having a CBD stone. Patient is having a cancer somewhere in the pancreas. So cancer in the pancreas and cancer in the bile duct, whatever it is. Now I should go for the next step. If it is a common bile duct stone, nothing to worry because I can easily treat them by doing a procedure known as ERCP plus sphincterotomy plus stone removal. So I have to go for a simple procedure in which using a side viewing scopy. Using a side viewing scopy, I'm going to show you all these images. Don't worry. Using a side viewing scopy, I am going to cannulate the bile duct and I am going to remove the stone and I am going to put a stent inside the bile duct like this, known as double pigtail stent. After removing the stone, I will put a stent inside the bile duct temporarily. That is known as double pigtail stent. And afterwards, I will plan for a laparoscopic cholecystectomy also. I will remove the gallbladder also. Laparoscopic cholecystectomy is done for those patients. So please remember, if it is a CBD stone, the gold standard treatment is treatment of choices ERCP plus sphincterotomy and stone removal. ERCP, sphincterotomy, and stone removal using a special endoscopy, side viewing scopy, and followed by laparoscopic cholecystectomy. Because gallbladder is having stone, no, so I should remove the gallbladder also later. Is there any other alternative for CBD stone? Yes, there is alternative for CBD stone. Another alternate procedure is, what is it? Another alternative procedure. Another alternative procedure is I can remove the CBD stone as well as gallbladder in the same sitting by laparoscopy. Laparoscopically, I remove the gallbladder, known as laparoscopic cholecystectomy. And I will open the bile duct vertically. See, remember, I should open the bile duct vertically and remove the stone from the bile duct by using a special forceps known as Desjardins forceps. With the help of Desjardins forceps, remove the stone and after that, keep a T-tube like this inside. Keep a T-tube like this inside. This is known as T-tube kept inside. This procedure is known as CBD exploration, also called as choledocho bile duct opening and removing the stone, known as lithotomy. This procedure is known as CBD exploration and choledocho lithotomy. So when it is going to be a CBD stone, how will I remove the stone? This is a classical finding. So if it is going to be CBD stone, this is a protocol for a CBD stone. If it is a cancer in the pancreas, I have to next send the patient for the investigation of choice for cancer pancreasis, CECT abdomen. CECT abdomen, triple phase CT scan is advised for those patients. I need to know whether the cancer is operable or inoperable. Everything can be detected by CT abdomen. So operability of the cancer is assessed. So I want to know whether it is operable cancer or borderline resectable cancer or unresectable cancer. 3 cancers I'm going to discuss later, but please remember, it is a borderline resectable or unresectable. I should know what cancer it is. So CT is gold standard now. So I have to confirm what cancer it is by doing a CT scan, and I have to do one tumor marker for pancreatic cancer. What is it? So tumor marker of pancreatic cancer is CA19-9. But CA19-9 is not always elevated. It is not elevated in 10% of them. It is not elevated though there is cancer. Who are those 10%? 10% of the patients, though there is a cancer, CA19-9 will not be elevated. They are not elevated in, who are those cases? Means Lewis antigen blood group negative cases. There is one blood group in our body which is not done commonly. It is known as Lewis antigen. That Lewis antigen negative patients will not have elevated CA19-9. So that is very interesting point. So they have false negative value. CA19-9 is not elevated in Lewis antigen negative cases. Please don't forget this point. So CA19-9 is a tumor marker of choice for pancreatic cancer. For bile duct cancer, if there is a bile duct cancer, what is a tumor marker? For bile duct cancer, we should do CA19-9 and also CEA. Both are done for bile duct cancers. Please don't forget. If it is a gallbladder cancer, what is a tumor marker? CEA is a tumor marker. See, any cancer nearby the bile duct can enlarge and obstruct the bile duct. So please don't forget. So better therefore, if you suspect cancer, do CA19-9 and CEA. Both are done. So gallbladder cancer, it is only CEA. Bile duct cancer, both CA19-9 and CEA. And for pancreatic cancer, it is CA19-9. These are the tumor markers which should be done after doing a CT scan. Okay. So now, so this completes the investigation. So this completes the investigation part of obstructive jaundice. Let me show you the images now. So I told you investigations, don't forget direct bilirubin increased, alkaline phosphatase increased, prothrombin time and INR increased. So just have an idea about the values. You might be asked the values in the exam. Prothrombin time, normal time is 12 to 16 seconds. And INR is less than 1.1. All these values just go through. So the biomarker is CA19-9, but the disadvantages of biomarker CA19-9 is it is elevated even in benign cases sometimes, but not so high, but it can be elevated. Patients with Lewis antigen negative are unable to synthesize CA19-9. Therefore, CA19-9 is the best tumor marker for follow-up. That is the best for follow-up, not for diagnosis. Okay. So this is a picture showing you what finding. What is this finding shown here? It is a picture showing you stone with the posterior acoustic shadow. This is a gallbladder stone on ultrasound. Gallbladder stone on ultrasound. This is a picture showing you posterior acoustic shadow. Don't forget this MCQ finding. This is an image showing you ERCP. You can see the side viewing scopy. I am seeing the pancreatic duct, bile duct, and you can see the gallbladder. Even intrahepatic bile duct is also seen. This is a classical image showing you ERCP image. This is an image of ERCP case. So any patient coming to you with an obstructive jaundice due to stone, we have to go for ERCP and remove the stone. This is an MRCP showing you stone in the bile duct and stone in the gallbladder. Stone in the bile duct and stone in the gallbladder. You can see the classical MRCP finding. This white color is nothing but bile. Bile acts as contrast. In a T2 weighted image, it's the bile which is acting as a contrast. Please don't forget this image. Okay, MRCP image. So this is one investigation. Though it is an investigation, it is now not done as an investigation. In cases of obstructive jaundice with a cancer in the proximal bile duct like this, like a hilar cholangiocancer known as Klatskin tumor. In a Klatskin tumor, I cannot pass, sometimes the jaundice will be very high, I cannot operate the patients. Such patients, I will go for a procedure to reduce the jaundice, that is by putting a tube into the liver like this. This is known as percutaneous. This image shown here is percutaneous transhepatic cholangiogram. The image is showing you percutaneous transhepatic cholangiogram, which will be going for a percutaneous transhepatic biliary drainage. I can drain the bile. PTBD, known as percutaneous transhepatic biliary drainage, can be done for that patient. So PTBD, that is known as PTBD. What is this investigation? This is an investigation showing you HIDA scan. It is not used for obstructive jaundice patients. Please remember, it is not an investigation for obstructive jaundice patients. It is a physiological flow. Physiological flow of bile is detected with the help of this. It is not helpful to study the anatomy or cancer or stone, nothing. It is a radionucleotide scan, which the hydroxyimmunodiestic acid taken by the liver is excreted into the gallbladder and into the bowel. It is only a physiological study of bile flow. Please don't forget, it is not helpful to diagnose anything. Not helpful for cancer or not helpful for stone. Then what is the use? It is mainly used for studying problems in physiology like sphincter of OD dyskinesia. So they are more theoretical points, just know the image. So it is used for sphincter of OD dyskinesia cases, not for stone or cancer. Don't forget this point. So once you have confirmed it is a cancer, before going for surgery, it is a mandatory for cancer head of pancreas, especially cancer head of pancreas and gallbladder cancer patients to do PET CT scan. So the image of whole body PET CT using the contrast FDG. So fluorodeoxyglucose. Fluorodeoxyglucose is used to diagnose whether the cancer is operable or not. And even gallbladder cancers, especially before going for surgery, we will look for any peritoneal mets also is done with the help of staging laparoscopy. So this is just, I'm giving you some images. What is this ERCP showing you? ERCP showing you there is a cancer in the hilum of the bile duct. Hilum of the bile duct. This is an ERCP showing you stone in the bile duct and gallbladder multiple stones. ERCP showing you gallbladder and bile stones and bile duct stones. This is an MRCP showing you cancer in the hilum, known as hilar cholangiocancer. This is the pancreatic cancer on a CT scan. You can see the classical pancreatic cancer on CT scan. I'll tell you there are three types of images you can use, types of findings in CT. I'll tell you now. And see this finding. What is this? In this surgery, in this image, you can see there are multiple clips being done. Means what? Previously, some surgery was done, like cholecystectomy. They have injured the bile duct, and the patient is having multiple clips. Can you see so many clips? Means what? Previously, there is an injury of bile duct that surgeon has tried to clip the bile leak or some bleeding and has caused so much of damage of the bile duct. This is a classical image of multiple clips. It's a finding to say previously cholecystectomy was tough. So what is the management of obstructive jaundice? There is a bunch of key you can see from the image. Obstructive jaundice is a disease and treated by surgeons with a bunch of key. We have multiple keys. We have to select the correct key for the correct hole. Otherwise, you cannot treat the obstructive jaundice. That is a concept here. So how to treat each obstructive jaundice by the ideal method. Let us now go on to one by one. I hope you are clear with one basic concept, that is number one, CBD stone. First topic I already told you, CBD stone causing jaundice. What is the treatment of choice? Treatment of choice is ERCP plus sphincterotomy. Cut the sphincter and remove the stones. ERCP, sphincterotomy, removal of stones. And stenting is the correct method. That is the gold standard treatment for CBD stone. That is already discussed, so I am completing it. Second, I am going to pancreas cancer. I am going to discuss about this topic because in exam you are going to get obstructive jaundice. Usually it is from a pancreas cancer. So please understand pancreas cancer clearly here. See, if you read obstructive jaundice, you are going to read so many chapters at the same time. Very important. So this is a bile duct. This is a bile duct. This is a major duct of pancreas. So this is the ampulla now. This is ampulla now. So I can see cancers causing jaundice in two places. 2 centimeter around the ampulla is called as periampullary cancer. 2 centimeter around the ampulla is known as periampullary cancer. And this cancer is known as head of pancreas cancer, which is common. Head or periampullary. Head of pancreas cancer is most common. I already told you periampullary cancer will have painless intermittent jaundice. They have painless intermittent jaundice. Head of pancreas cancer will have what finding? Head of pancreas cancer will have painful jaundice, which is progressive jaundice, progressive painful jaundice. Very important. So please remember, these are the two cancers which can cause jaundice. One is progressive painful jaundice, another is painless intermittent jaundice. So now you should know the anatomy of pancreas. What is this vein which is going below the neck of pancreas and coming out like a portal vein? And this is splenic vein. So splenic vein and this is portal. See, understand this anatomy. This is superior mesenteric vein which enters the neck of pancreas via a tunnel known as tunnel of love. This tunnel was once upon a time very important because it is called as tunnel of love. The surgeons wanted this tunnel to be patent. If this tunnel is normal, then only I can operate. If the tunnel is infiltrated, we cannot operate. This is an old custom, okay, but it is not followed now. Just remember, tunnel of love is at the level of neck of pancreas, where SMV joins with splenic vein. Superior mesenteric vein joins with splenic vein and becomes portal vein like this. Superior mesenteric vein joins splenic vein and becomes portal vein. So cancer can infiltrate into this portal vein. And next, this is an artery next to, these are all posterior to the pancreas. What is this artery? Can you tell me what is this artery? This is superior mesenteric artery. This is superior mesenteric artery. And this is celiac artery. From celiac artery, you can see this is hepatic artery going like this. This is common hepatic artery. So this is superior mesenteric artery. This is celiac artery. See, now the cancer can infiltrate into these vessels. So when will you say the cancer is borderline resectable? Can you tell me? There are three categories based on CT scan finding: borderline resectable and resectable and unresectable. Very interesting concept. Though this is too much for final year exam, this is an upcoming topic and it is there in Bailey and Law. 28th edition Bailey has mentioned about these three categories. Resectable cancer is a cancer which has infiltrated superior mesenteric vein or portal vein less than 180 degrees. Simple. The tumor has infiltrated like this into the superior mesenteric vein or portal vein less than 180 degree means I can cut the portal vein and suture it. That is resectable cancer. When superior mesenteric vein or portal vein infiltrated more than 180 degree, it is borderline resectable. Superior mesenteric artery less than 180 degree. Common hepatic artery less than 180 degree. Okay, so these are all coming under borderline resectable. Unresectable is superior mesenteric artery more than 180 degree, common hepatic artery more than 180 degree, or celiac artery infiltration. So these are said to be unresectable cancers. When will you say a pancreatic cancer is resectable, borderline resectable, and unresectable on CT scan? So borderline resectable cancers, I will give them neoadjuvant chemotherapy and decide for surgery later and plan surgery later. But for a resectable cancer, directly taken for surgery. So tell me, what is the surgery done for both the cancers, periampullary and head of pancreas, both same surgery? What is it? The surgery is known as Whipple's. So definitely the examiner will ask you to explain about Whipple's operation. It is also known as pancreatico-duodenectomy operation. So pancreatico-duodenectomy operation is known as Whipple's. Please understand the image I am drawing. Esophagus, stomach, this is duodenum. Okay, this is duodenum, this is pylorus of the stomach and duodenum, and this is the pancreas. And this is neck of pancreas or tunnel of love. This is head, body, tail. And this is the picture showing you bile duct. Bile duct, gallbladder, common hepatic duct. This is the anatomy now. Now, for 5 cancers, I will do this operation. They are periampullary cancer, number 1. Periampullary cancer. Number 2, head of pancreas cancer. Number 3, distal bile duct cancer. Distal bile duct cancer. Number 3. See, I'm going to tell you 5 cancers where I will do Whipple's. Periampullary cancer, head of pancreas cancer, distal bile duct cancer, second part of duodenum cancer, D2 cancer, and gastrinomas are usually seen in Passaro triangle. So gastrinoma is a syndrome causing Zollinger-Ellison syndrome. They are seen usually in the Passaro triangle. So out of syllabus here, but just remember Passaro's triangle, gastrinomas. For these 5 cancers, I am going to do Whipple's operation, in which what are the structures I am going to remove? I am going to remove distal stomach. Please understand, distal stomach. Entire duodenum I have removed. Head of pancreas I have removed. Gallbladder, bile duct I have removed. So after removing this, what is remaining? After removing this is the stomach remaining. This is the bile duct remaining. This is the body and tail of pancreas remaining. So stomach, bile duct, in fact, common hepatic duct and pancreas, body of pancreas. So what will I do now? Now I will bring a jejunum and anastomose with 3 structures. 3 anastomoses are done. Pancreatico-jejunostomy, gastro-jejunostomy, hepatico-jejunostomy. 3 anastomoses are done. PJ, GJ, HJ. So 3 anastomoses are done in Whipple's operation. So Whipple's operation is removal of pancreas and head of pancreas and duodenum. Head of pancreas and duodenum is removed and the patient is now done 3 anastomoses, GJ, PJ, HJ. So after Whipple's operation, what is the most common complication? Since I am cutting the pylorus, patients can develop delayed gastric emptying. Patients can develop delayed gastric emptying. This is a very common complication and most dangerous complication. What is most dangerous complication? Most dangerous complication is, please don't forget, pancreatico-jejunal anastomotic leakage. Pancreatico-jejunal anastomotic leakage is the most dangerous complication. So such a pancreatico-jejunal anastomotic leakage, the pancreatic juice will cause so much of damage, and the patients can die. Most common cause of death is also, this is the reason. Most common cause of death is PJ leak. Please don't forget this. And therefore, to avoid this dangerous complication, usually we keep a drain. Now, surgeons always keep a drain in the PJ anastomotic area. And for PJ anastomotic area, we have kept a drain. No, we have to follow rule of 3 to lose. C for drain. On 3rd post-op day, the DT fluid amylase is 3 times more than serum amylase. It means what? In the DT, the fluid is coming, no, that fluid will be sent for amylase. It is 3 times more than serum amylase. This is called as rule of 3. So DT amylase is 3 times more than serum amylase, is called as rule of 3. Don't forget this point. On a 3rd post-op day, if there is DT amylase more than 3 times, means we call it as pancreatic fistula. We call it as pancreatic fistula. That complication is called as pancreatic fistula. So the common complication of Whipple's operation is delayed gastric emptying. Most common cause of death is PJ anastomotic leak. And to avoid that, we are going to keep a drain. And in the drain, on a 3rd post-op day, DT amylase is 3 times more. It is called as pancreatic fistula. To avoid this DGE is avoided by one procedure. What is it? Delayed gastric emptying is avoided by one procedure in which I will not cut the pylorus. I will preserve the pylorus like this and cut at the level of D1. Okay, cut at the level of D1. Bile duct is as such same. Pancreas and body is same. Now I will bring the bowel and anastomose in such a way, PJ, here DJ, and here HJ. Instead of doing gastrectomy, I have preserved pylorus. This is known as pylorus preserving Whipple's. Pylorus preserving pancreatico-duodenectomy. This is known as pylorus preserving pancreatico-duodenectomy, known as Longmire and Traverso procedure. Longmire and Traverso operation. So Longmire and Traverso operation is the name given for this pylorus preserving pancreatico duodenectomy procedures. So this is Longmire and Traverso procedure, but this is updated in Bailey and Law. A new update Bailey points. So Longmire and Traverso operation is updated in Bailey and Law. So please don't forget these basic concepts. So you can see a patient having CBD stone, we are removing it by an ERCP. You can see the stone is removed by sphincterotomy and we are passing a stent inside. So classically, you can see the image showing you using a Darmia basket. We are removing the stone using a Darmia basket type of stone removal. That stone removal forceps is used and the stone is removed. And after removing the stone, we have kept a stent inside the bile duct. It is a post ERCP stent kept inside. Okay. What is the name of this forceps shown here? Can you tell me what is the name of this forceps? This is known as Desjardins forceps. Desjardins forceps for CBD stone removal. So these are the various types of stents we use. So this is one type of stent you shown here. I already showed you one stent. This is a stent known as DP stent, double pigtail stent. In this stent, there is no pigtail, but there is one like a frong, one frong above, one frong below, so that it will not come out. This is Amsterdam stent. This is Amsterdam stent. And this is for cancer patients. We put self-expanding metallic stent. For cancer, if you are not going to operate, we will put a stent inside the bile duct for inoperable cancers. That is known as self-expanding metallic stent called as SIMS. So SIMS, Amsterdam, DP stent, just I'm giving some images. So this is a T-tube. You will be getting an exam as a instrument-based question in the Viva exams. It is a T-tube which is kept in the bile duct known as T-tube, Kerr's T-tube. This tube is also called as Kerr's T-tube. Okay, so this is a picture showing you T-tube is kept inside, and before removal of the tube, I should do T-tube cholangiogram. I will ensure there is no obstruction by putting contrast. It's a classical video showing you, image showing you T-tube cholangiogram. Okay, before removing. So if there is a stone, I have to do something which is beyond the scope for this chapter now. So any stone in the bile duct, we have to go for many techniques, but please remember before removing the T-tube, I should do a T-tube cholangiogram. This is a picture showing you T-tube kept inside. So some surgeons, instead of keeping a T-tube, we will directly do anastomosis with the opened duodenum like this. So instead of keeping a tube, I can open the bile duct and anastomose it with the duodenum directly. So this is the image I told you, no, PTBD, percutaneous transhepatic biliary drainage. You can see the classical image of a stent kept inside the liver through the bile duct. You can see bile is pouring out. This is known as PTBD, percutaneous transhepatic biliary drainage. So for exam, the final conclusion is CBD stone causing jaundice, ERCP and stone removal followed by laparoscopic cholecystectomy. Or single sitting, I can do cholecystectomy and cholecystectomy in a single sitting. Same time, I can open the bile duct and remove the stone, and I can also remove the gallbladder. One. This is a T-tube, I told you, this is a T-tube cholangiogram. Scenario 2. If a patient had previous surgery and patient having a bile duct stricture like this causing jaundice, I will bring a loop of jejunum and anastomose like this. This is known as hepatico-jejunostomy. For example, this is a stricture here. I can bring a bile duct, I can bring a jejunum and anastomose like this, known as HJ. Hepatico-jejunostomy for post-cholecystectomy biliary stricture causing jaundice. Scenario 3, distal bile duct, periampullary head of pancreas cancers. I told you the operation is Whipple's. So don't forget the CECT protocol. You can see on CT scan, here there is a cancer which is just infiltrating or just touching the superior mesenteric vein. So you can see this is a periampullary growth with a dilated bile duct and all seen on a CT scan. So CT scan is a classical image. You can see the MRCP showing you double duct sign, dilated bile duct, dilated pancreatic duct. This is known as double duct sign. So yes, another ERCP also shows double duct sign. So this is a picture showing you reverse 3 sign, but these are all not important. These are obsolete signs. Only in PG entrance exams you can get this MCQ. Because of the periampullary cancer, the duodenum looks like a reverse 3, also known as epsilon sign. Epsilon sign. So you can see a Whipple's operation going on here. You can see the portal vein. I'll show you the videos of this. You can see a portal vein infiltrated. The portal vein is resected and reconstructed. So this is a portal vein reconstruction done for a patient. So this is Whipple's operation specimen. These are all Whipple's specimen of Whipple's operation. You can see head of pancreas, Whipple's operation. So all these are various specimens of Whipple's operation. So we are going to do 3 surgeries. I told you already, we have to do pancreaticojejunostomy, hepaticojejunostomy, and we have to do GJ, gastrojejunostomy. 3 surgeries has to be done. And I told you one more surgery where instead of removing the duodenum, I will preserve the pylorus, that is known as pylorus preserving Whipple's. So I told you what is advantage of pylorus preserving. They are saying there is delayed gastric emptying is decreased. That's all. That is what they are saying. SMA resection is now done up to less than 180 degree. I told you it is known as borderline resectable cancers. In such cases, we can go for a SMA resection. So don't forget what is the meaning of borderline resectable cancer. I told you. So these are some of the Whipple specimen. And finally, one topic I didn't discuss is cholangio cancer. Let me discuss about this as a last topic for before going for your doubt clearance. Bile duct cancer. Bile duct cancer. So I am discussed about bile duct stone, pancreatic cancer. Now this is bile duct cancer. Please understand, this is right duct, this is left duct, and this is the common duct. So now cancer can happen anywhere in the duct. For example, it can be in the distal bile duct. What is the treatment I told you? For a distal bile duct cancer, treatment I told you already, Whipple's operation. Okay, that is no doubt. A cancer in the mid CBD, I can cut the bile duct 1 centimeter above and below and resect like this. 1 centimeter margin, I can resect it. Resection can be done. A cancer in this place is called as Klatskin tumor, also called as hilar cancer. Most worst thing is this is the most common site of bile duct cancer. In the bile duct, where is the cancer common? It is common in the hilum. Klatskin tumor is common. So hilar cholangiocarcinoma. This is called as hilar cholangio means bile duct cancer. So now there is a classification of hilar cholangiocarcinoma known as bismuth correlate classification. Bismuth correlate is a classification of bile duct cancer. Repeated PG entrance exam question. This is a repeated PG entrance exam question. So please don't forget. This is common hepatic duct. This is right. This is left. Okay, this is right and this is left. And these are other upcoming branches, second order branches. So these are second order branches. I'm going to tell you the classification now. To understand the classification, bismuth correlate type 1. Type 1 is a cancer which is away from the hilum. This is type 1. So hilar cholangio cancer away from the hilum, away from hilum. Type 2 is at the hilum. At the level of hilum, there is a cancer. Okay, at the level of hilum. 3A, the cancer is in the hilum, infiltrating into the right side second order ducts. Right side second order ducts. 3B, the cancer in the hilum, infiltrating into left side second order ducts. Left side second order ducts, 3B. 4 is a cancer involving both ducts, both second order ducts. This is 4. See, please remember 4 is inoperable cancer. 4 is inoperable cancer. 4 is inoperable. We cannot do anything. Whereas for a 1 and 2, I can resect only the bile duct. Bile duct resection is enough. No need of hepatectomy. Whereas 3A and 3B will need extended right hepatectomy for right side case, extended right hepatectomy for 3A, and extended left hepatectomy for 3B. Extended left hepatectomy for 3B. So we have to do an extended resections. I hope you know the liver segments. So liver segments, I'll tell you what is the hepatectomies. This is segment 2, this is 3. This is segment 4A, 4B. This is 5, 6, 7, 8. These are the 8 segments. And this line is known as Cantel's line. So when I remove the segments 4B, 4A, 5, 6, 7, 8, it is called as extended right hepatectomy. 5, 6, 7, 8, 4A, 4B is known as extended right hepatectomy. When I remove the segments like 2, 3, 4A, 4B, 5 and 8, it is called as extended left hepatectomy. So 2, 3, 4A, 4B plus 5 and 8, that is known as extended left hepatectomy. When I remove 5, 6, 7, 8 plus 4A, 4B, it is known as extended right hepatectomy. So extended right hepatectomy done for 3A cases and 3B cases, extended left hepatectomy is done. So these are the points you should not forget. These are all, whatever I am discussing is that exactly line by line is there from Bailey and Love. If you go through Bailey and Love, you will see the direct lines there. So this is a classification of bismuth correlate away from the hilum, at the hilum, involving right side second order duct is 3A, involving left side second order duct is 3B, 4 is involving both right and left ducts. Okay, by bismuth classification, don't forget. So other rare scenarios, I'm going to give you some images, very, very rare cases. Don't tell these diagnoses in the exam, you will get into trouble. Just for completion's sake, I'm telling you, an Ascaris lumbricoides can cause obstructive jaundice. An Ascaris worms, especially in Indian setup, we have many times worms entering into the bile duct that can cause obstructive jaundice. So you can see very carefully, you have to take out the worm by ERCP. Very important. Why? Because when I try to catch with the snare, it can get cut and half of the worm will go inside. You should be very carefully removing it without injuring the worm, not bile duct. If you injure the worm, half of the worm will go inside. So this is Ascaris showing you obstructing the bile duct, causing jaundice. So this is hydatid cyst. Hydatid cyst can rupture into the bile duct and the hydatid membranes can cause jaundice. These are rare scenarios. Please don't tell in exam. Just for completion's sake, I'm telling you the other rare cases of obstructive jaundice, hydatid cyst. So tell me, what is this syndrome causing obstructive jaundice? There is a stone in the gallbladder which is compressing the bile duct. The stone has not come to the bile duct. It is in the gallbladder only. The stone in the gallbladder neck compressing the bile duct called as Mirici syndrome. It is called as Mirici syndrome. The gallbladder stone compressing the bile duct is called as Mirici syndrome. That case is given here in the image of Mirici syndrome. Stone compressing the bile duct causing obstructive jaundice. So what is the cause of jaundice in this picture? MRCP shows a sign known as meniscus sign. So that means what? There is a stone here. It's a meniscus sign. So you can see the same meniscus sign in a T-tube cholangiogram. This is a T-tube cholangiogram showing you a stone in the bile duct known as meniscus sign. This is also a meniscus sign. So meniscus sign is stone in the bile duct. In the gallbladder, you are seeing a stone with the air. What is this air known as? This is called as Mercedes-Benz sign. Mercedes-Benz sign is a sign of air in the gallstone. Mercedes-Benz sign is an air in the gallstone. Okay, this is about the obstructive jaundice. I want to see the doubts because many doubts I could not see when I'm discussing that. Let us come back to the doubts one by one. I think how to palpate for gallbladder from Sri Aravindan. So please remember, for palpating gallbladder, keep your hand parallel to the right subcostal margin, but don't start from above downwards. You should start from right iliac fossa. Start from right iliac fossa. You should go slowly towards the liver. So you should ask the patient to take a deep inspiration. Every time when there is an inspiration, the gallbladder will come and touch your hand. Okay, that is very important to palpate the gallbladder. You should not go and press the gallbladder. You cannot find out. You have to come from below. Gallbladder should come and touch you. You should not go and touch the gallbladder. Okay. If gallbladder, Jacinta is asking, if gallbladder also not palpable, also we can say periampullary cancer. Yes, sometimes I'm telling you, this is not a fixed rule. It's not always fixed rule. Many times in a gallbladder, in a cancer, gallbladder may not be palpable because the bile would have drained, and sometimes it will not be palpable, but it's only a differential diagnosis. Gallbladder may not be palpable in a periampullary cancer who had sloughed out and the bile has passed out. Okay, that is possible. That is possible. Yes, most of you told Thomas sign. Jacinta Gracelyn is asking, can cholangitis occur in malignant obstructive jaundice? Please remember, cholangitis means what? Bacteria entered into the bile duct. It is usually in a stone disease, there is already some infection in the gallbladder or the stone that causes cholangitis commonly. In a cancer cases, usually they don't develop obstructive jaundice unless you do some ERCP or PTPD. A cholangitis in a malignant obstruction is very, very rare. But a cholangitis can occur in malignancy also if it is a partial obstruction. If it is a partial obstruction, cholangitis can happen in malignancy. But cholangitis is common in stone disease only. Please don't forget it. Okay. Dumping syndrome seen in Whipple's. Yes. Whipple's dumping syndrome is seen. Because of the GJ, we can also see dumping syndrome, but more common than dumping syndrome, here it is commonly seen syndrome is a case of delayed gastric emptying. Delayed gastric emptying is more common than dumping. So any GJ when you do, there will be dumping. But since these pancreatic cancer patients are usually advanced cancers, they will not survive to the stage of dumping. They won't come to you with the typical early dumping, late dumping. That much year they won't live. Most of the patients, especially head of pancreas cancer and all, they will die in 2 or 3 years. So, but periampullary cancer will have long survival and they can develop the dumping syndrome. Those patients can develop dumping syndrome. Pancreatic cancer in CT 3 types. Yes, pancreatic cancer, I told you, 3 types of pancreatic cancer. Resectable, borderline resectable, and unresectable. So resectable is when the SMV and portal vein involved less than 90 degree. Less than 180 degree. When SMV portal vein involved more than 180 degree, it is borderline resectable. When it is involving SMA or celiac artery more than 180 degree, it is unresectable. Okay, these are the 3 types of pancreatic cancer: resectable, borderline resectable, and unresectable. This is a new update in 28th edition Bailey. Please go through that. Yes, any other doubts you have, please tell me, because this is a basic. If you know about this much, if you know in exam, that is more than enough. But if you have any doubts, please post in the chat box. So let me give a nutshell now. Nutshell of this obstructive jaundice nutshell. So a patient coming to you with an obstructive jaundice, what are the clinical features you'll have? You'll have yellow urine, clay stools, scratch marks are the 3 important features. Itching, yellow urine, clay stools. Don't forget this. And obstructive jaundice patients who are coming to you for your exam will be only 2 cases. One is stone case, another is cancer case. So stone cases will have pain and they would have had fever also. Pain and fever would have been seen in stone. And it is a classical feature, pain and fever. And cancer, it is painless in periampullary cancer, or it can be painful also. Usually fever is not present in cancer cases. So the most interesting finding is in a stone disease and a cancer disease, stone is very common in young females. Stone disease is common in young females. Cancer is common in old males. Cancer is common in old males. And there will be weight loss. In a cancer patient, there will be weight loss. So stone patient, they are not going to come very late. So there is no weight loss. There is no weight loss in these patients. And whatever it is, the interesting finding which is going to give you a pakka clue is Courvoisier law. Please remember, gallbladder is palpable in cancer, not palpable in stone. This is Courvoisier law. I'm telling you again and again, you will only get a cancer case of obstructive jaundice. They won't keep you stone, because stone in the bile duct is an emergency. So that patient need to go to theater or to the ERCP. So they won't keep it for your exam. So when it is stone or cancer, you have to tell about it, whether it is a stone or a cancer, and go for a diagnosis. After giving the diagnosis, tell about the protocol in investigations. So you should tell there is increased alkaline phosphatase is the most sensitive marker of obstructive jaundice. CA19-9 is a tumor marker of cancer pancreas, and the gold standard investigation to diagnose is MRCP. MRCP is an investigation of choice for obstructive jaundice, because that will tell whether it is a stone or a cancer clearly. Even ultrasound will not tell. Ultrasound will be the next done investigation, but it is not best. When it is stone, go for ERCP and removal of the stone. When it is cancer, you should now send the patient for CECT, abdomen, PET-CT, and diagnostic laparoscopy. So these are the package of cancer cases. CECT abdomen, PET-CT, D-lap, all those things will be done when the patient is going to be planned for surgery, and the planned surgery is Whipple's. So in between this, the examiner can go into discussion of bile duct cancer. He can go inside, because bile duct cancer is very rare exam case. So you can go into a bile duct cancer. The topic can go into a gallbladder cancer infiltrating bile duct, or other rare causes. They can ask just as a viva, like a Mirici syndrome. What are the other, any other rare causes like that? If they ask, you can tell hydatidis is structured into the bile duct. Like that, you can tell very rare causes alone. Don't tell everything. Okay. So whatever you're going to tell, you should be confident. Then only you should tell. Otherwise, you'll be getting questions from that topic. Okay. Is it clear? So any doubts you have, please tell me, or else you have a quiz program to be done. Dr. Lakshmi is going to connect a quiz program for you. So any doubts you have? No doubts? Seeing the question answer chat box. You can download these notes from Surgery Sixer. Okay, from Surgery Sixer, you can download these notes. Yes, I think Dr. Lakshmi, I think there is no doubts from the students. Shall we stop? D-lap is always done for any cancer. Jacinta is asking what about D-lap. D-lap is a procedure which should be done for any cancer which is going to be operable inside the abdomen, like gastric cancer, or even liver cancer, or gallbladder cancer, or even pancreatic cancer. Before going for a major Whipple's operation, we have to put a D-lap to look for peritoneal mets. Small peritoneal mets will not be picked up by PET-CT. To find out the small peritoneal mets, we will do this D-lap. Otherwise not for any other reason. So if D-lap is showing mets, then it should show that tumor is inoperable. The tumor is going to be inoperable. That point you should not forget. Okay, we will not operate those cases. Yes. Any other doubts? So had a nice interactive session. Please go through this PDF and the material. This is enough for final year students. This topic, whatever I discussed, is more than enough for your exam. It is for final year level. For the super specialty level, we'll be going more deeper. But for final year exam, this is more than enough for your exam. Okay. So please go through this. Unresectable cancers, we have to put a stent. You saw one image, self-expanding metallic stent. That is the stent which will be used for unresectable cancers. Self-expanding metallic stent will be passed into the bile duct so that the bile will drain for inoperable cancers. So we have to palliate the jaundice. For them, we can do that stenting. And sometimes we can do palliative triple bypass also. For inoperable cancers, we can do triple bypass, like cholecystogegenostomy, gastrojejunostomy, and jejunostomy, only for inoperable cases. So best treatment now for inoperable cancer pancreas and inoperable cancer bile duct is bile duct stenting. That is the latest answer from Bailey and Lowe. So you can go for a self-expanding metallic stent in inoperable cancers, because anyhow they are going to live only for 6 months to 1 year. So self-expanding metallic stent will function for 6 months to 1 year. Okay. Yes. Okay. Thank you. Thank you all. So please attend the quiz program. Dr. Lakshmi.
Yes, sir. Thank you so much, sir, for this wonderful session.
Thank you.
I'll be sharing the link for the quiz now, and I request all the participants to stay back for that. And please don't forget to register for MedMeet 2.0, which is to be held on the 2nd and 3rd of this December. There will be poster presentations, case presentations, workshops, and more with cash prizes. So I request you all to register, and I'll be sharing the link now. It's
Thank
just a
you.
20-minute quiz.
Yeah.
1 second.
Thank you. All the best.
I've shared the link now. Is it available to all? There are cash prizes with this quiz, so please make sure you do attend it. It's only a 20-minute quiz. The time is started now, so I request you all to do it as fast as I hope everybody is able to access the quiz. Please do attend it. There are cash prizes at the end.
So we're closing the quiz session. Thank you all for attending. The time for the quiz is up. You can leave the session now. Thank you so much for attending.